Thank you, Frida. I appreciate it. And Mr. Keith Wood.
I'm Keith Wood, and I've been working with people diagnosed with a serious mental disorder and have been acutely, quote, a danger to themselves or others for about 40 years. I earned my gray hair that way. In fact, just yesterday when I was preparing to come here, I was planning to leave at 5, and at 5 minutes to 5 or something, a group of students came to me and said, Dr. Wood, this person is meeting all the criteria for being suicidal. This person definitely needs to be in the hospital. We have to have a licensed clinician to be able to sign that, and I understand you're the expert, so, okay. So I go, well, it has to be pretty quick because I have to catch this plane. And they said, oh, no problem. And I go in there, and of course, this hits at every issue that I think we need to deal with when we're talking about dealing with people who have, quote, serious mental disorders and who may be suicidal. And what do we do? And what are all the issues that happen with that? And I said, okay, God, you're real. You kind of gave me this right now so I can understand some of the problems. And one of the problems is, do we have time to talk to people like this? Do we even get paid for doing that? And what is involved in when you're working with individuals who have a disorder maybe called schizophrenia or bipolar disorder or major depressive disorder with psychotic features, or many of these disorders? What is it about them? And is suicide really an issue with that? Does it fit with the other issues that most of our literature is on? This was a classic case of what I think this conference is oriented toward. It's really, what do you do with individuals who, you're talking about trying to do prevention with suicidality among individuals who have serious mental disorders. And the data that we use, and exactly what the students used, was all the criteria that kind of says, how do you predict someone who's about to maybe do something dangerous to themselves? You know, it's all that classic information really doesn't necessarily fit with the population who I've worked with. I mean, does insight to having a condition, about having a disorder, does that increase or decrease the likelihood of someone being suicidal? Interestingly enough, in the traditional population, many times we'll say, oh, you're depressed, and you understand that depression is associated with maybe suicidality, and they go, oh yeah, I kind of get that, yeah. So if we deal with the depression, you say that to someone who is diagnosed with schizophrenia, and they go, no, I don't. And I don't have schizophrenia. I don't have a disorder. Most of the time, they don't. The ones, and then we bang it in our heads, no, you do. You have to accept that. You know what happens? If they start accepting that, you actually increase the likelihood of them being suicidal. What? I mean, the very approaches, in some ways we don't even recognize that, because many times the association of this disorder, which is often associated with many of the factors that we know are associated with potential suicidality or people taking their lives, has been associated with the term hopelessness. Some of it is the isolation, it's the lack of caring, many of the things that we've talked about. What happens with the label? It's so interesting, even the terms that we use to call an individual, we use in labeling an individual, the terms we use to talk about even the problem. So here I am, now a little after 5, talking to someone, and I'm in a room, and there are 3 other clinicians in this room. And I'm walking in, and I'm getting ready to say, okay, I guess we need to put you on. I'm in Georgia, and we have involuntary commitment. If we're going to see somebody who's maybe a danger to themselves or others, it means that we end up having to do a commitment form, and we pull in and have some security come and get them and handcuffs them. And what are we doing? And then take them over to be in an emergency room, and then to maybe be hospitalized for a few moments, and then what do we know about that? Well, we know that they suddenly become patients. We understand that they start losing their power of control. And what our business is, and what we know to help people not be as suicidal, is to actually teach them to have more control of their environment. What do we end up doing? Oftentimes, what we do actually may increase the likelihood of those individuals actually becoming suicidal. You take away their power, you take away their hope, you take away their control, and we're trying to develop that. And here I am weighing all that as I'm talking to someone who fits all the criteria that says, oh yes, they should be in the hospital, they are a danger to themselves. Concurrently, I just read an article that our newspaper had just put out, I guess in preparation for suicide prevention or whatever it is. And you know what the primary measure of how well a behavioral health system was how many suicides people commit, how many suicides that are committed. So the measure of success, here you are a provider, here you are a clinician, you're working with a population that has the high risk. Yes, I'm working with people who have serious mental disorders, risk goes up. I'm working with people who probably have just gotten out of the hospital. And who's more likely to, when are you more likely to be suicidal? It just happens that right after you get out of the hospital, boom, you're there. I'm working with individuals who are likely to have a history of suicide attempts. I just talked to my group, one of the groups I'm working with, and I asked them, how do they handle problems? Teaching them coping skills and so on. What's their primary coping skill? Well, if something happens, I just decide I'm going to be suicidal. It is almost like a coping mechanism. Sometimes the thoughts are not even the way we traditionally think about it. I'm feeling so depressed, or I'm feeling like life isn't worth it or something. Many times you ask them that question, that's not the reason why they may be thinking about taking their lives. And so unless we are paying attention to the persons, especially individuals who were diagnosed with more serious behavioral disorders, many times their reason for taking their lives or having even those thoughts may be associated with something totally different. I just talked to someone who said, actually, I really want to take my life, not to die. I want to be able to deal with this voice that this person has been going after me, bugging me for years, and the only way I can get her is to go and take my life so I can go in here and I can kill her. That's what I want. That's her thought. That doesn't fit with our traditional way of looking at measuring these kinds of things. And I think that's part of what all those issues just popped up right then. So here I am talking to this lady. I'm realizing I don't have much time, but realizing that one of the most important pieces that we can have when we're dealing with this population is to be able to have time with them and to develop the relationship and to express that kind of concern. So I kind of started thinking as I'm talking to her, and there's another fact that the more we make these individuals feel like they are they and not us, the more we stigmatize them, the more we make them estranged from ourselves, the less we are able to connect with them. I really appreciated hearing earlier when someone talked about nothing about us without us, when they talked about kind of the normalization that happens, when someone's talked about, suicidal thoughts are not so abnormal. People have those thoughts. And so as I'm talking to this person, and when she talked about maybe thinking about dying and how she couldn't deal with things right now, my response was, I can understand that. That's not such an unusual thing, especially under the circumstances in which you are right now. What a difference happens. What's so interesting is when you're working with such a population, much of the work has been crisis-oriented. It has been fixed on how do I protect myself from the danger of someone actually doing something to harm themselves or helping someone else under my watch. I have to protect myself. In fact, when I'm teaching, oftentimes I say, make sure you ask people about if they're suicidal or not, and you document something on that to protect yourself. But in actuality, if I'm going to work with prevention in this population, and I'm seeing this time, so I'm running out of time here, or out, I'm thinking, in actuality, what I want to do instead is to be able to empower that person, to incorporate that person in the whole decision-making process. And in that process, now my focus then has to be on that person and their welfare. And if I'm thinking about prevention, I'm actually empowering them, not protecting myself and taking away that power. So in some ways, that next thing I know, I am now having an extended conversation. I'm including the other people who are in the group, and I'm saying we're working as a team. And in that decision, I guess we would do the equivalent of creating a safety plan or whatever. We end up talking about some future and doing some things, and every once in a while check my messages to make sure that she followed through with some things that happened today. And needless to say, I did not end up hospitalizing her, and we worked with that plan. But this is a challenge of our system, because it takes time. Do we get paid for doing this? I mean, who can do that? Put 3 or 4 people in a room together? Who's paying for, how is that? How can you even bill for that? What do we do with our systems? Many times the way that we can work with individuals the best is actually much larger than the individual and the crisis work that we do. It is really pulling together other people, pulling in the family members, pulling in other people in the community, pulling in actually providers. There's all kind of issues that I think are associated with how do you do prevention, suicide prevention, with a population that we have almost by definition made them passive recipients. Is there a question about why we might see higher rates of individuals with these disorders having completed suicides? I think, as some people might say, one of the things we should consider is even the way we treat them and the way we manage them may have a lot to do with the outcomes that we've been seeing and some of the challenges we have in terms of things that we can do to make differences. Thank you.
Great. Thank you, Dr. Wood.